So welcome everybody again. This is the second part of this episode, and now I would like to go into more detail of why we need these pragmatic, affordable, and practice-changing real-life clinical trials in oncology. And I urge you to look into this publication that is mentioned below in the slide, because actually it provides a lot of important and information, but also food for thought, so that you can take your own conclusions about what is happening in terms of the trial conduction that we have nowadays. And the fact is that in the last 10 years, each trial we are recording approximately 3 million data points per trial, which is enormous amount of data. The volume of the data that we are collecting also it's translated in the number of pages that we need to fill in the ECRF that passed from 55 to 177 pages per trial. This leads to an accumulation of data that is absolutely amazing, but huge. But when we look into the percentage of the data that is actually used for, that is actually related to the primary endpoint, which is in principle why we are conducting the clinical trial, we'll see that only 5% of this data that we collect are actually associated with this primary endpoint, which is quite strange because this should not be the case. When we look into the primary publication, we also see that approximately 20% of the data are actually included in the primary publication, but the rest of the data, it's not there. So what are we doing with this extra 80% of the data? This is a very important question. And finally, the majority of the trials actually do not include this societal cost-benefit analysis. It is extremely important for us to understand how we can put these new therapies or have these new therapies available for patients when the trials are finished. Also, a very important aspect that is discussed here is the number of inclusion criteria that is considered nowadays for the clinical trials. The number almost doubled in the last 30 years, which leads to the fact that the majority of the patients that we would consider for a clinical trial don't fit. We have a very stringent inclusion and exclusion criteria, leading to a very small number of patients that can be included and limiting the possibility of generalizing the knowledge that we generate with these clinical trials to the population that we treat in our daily practice. And this obviously leads to the question if our research is representative. And I would say that in the majority of the cases, the research is not representative, and probably it's not so representative so that including the regulatory agencies actually provided some guidance on how we should conduct clinical trials and how we could increase the representativeness and the diversity in clinical trials. There are some documents out there and some, I would say, guidance on how this representativeness could be increased, but also analysis that looked into the trials that have been conducted already and looked if these trials were representative. And one of the reports that I would like to mention to you is this TRANSCRIPT report that looked into more than 300 sponsored industry studies to look if the type of population that was included was actually representative of the population that we would like to include. And in the reality, there is an overrepresentation of white patients and patients between 18 and 64 years old, and an underrepresentation of racial and ethnic minority patients and also patients that are older than 64. This is an analysis conducted in clinical trials that done in the United States. In Europe might be a little bit different, but these are very interesting data that we would like to that we should take into consideration. EMA also issued a couple of guidances on the diversity of clinical trials and how we can increase the diversity of the clinical trials. It says that in principle, the patients that we include in clinical trials should be the ones that represent the patients for which we want to have the therapies available in real life. But it doesn't say a lot about the social demographic characteristics that should be considered and how this should be identified. On the other hand, they also provide some flexibility in terms of this representativeness depending on the phase of the trial. And this operational definition of representativeness is still missing in this guidance.